And at the 3-month interval, 100% of our patients who were on the Q day were compliant. Nobody had flared. 75% were compliant with which makes them, by definition, non-adherent now, with the BID or TID regimen. No flares in that group either. But then by 6 months, look at how even in the Q day, you've got a drop in your adherence rate to 75%. So now they've met the definition of non-adherence. This is a trial where I'm following them, and they're still not doing it. And I've given it to them once a day. I can't do any better than that, and still they're not taking it. So again, here is that 3-month critical window that again is showing up that perhaps this is where you have to do your intervention for the importance of why you need to take your medications. So we published this, and that sort of set the tone for, hey, you know what, that it might be that you can actually do this, give 5-ASAs once a day for maintenance. And so I took this on the road, if you will, and a couple of other centers joined on. And so we got about 50 to 60 patients at that point. And then we published in 2008 in this obscure journal called Patient Preference and Adherence, and just showed that, again, at 12 months, that non-adherence was associated with recurrence, and that if you were adherent, you were still going to have a chance of flaring, but not over that of somebody who was taking their medication, and that perhaps you really could do this once a day. All right, so that was me on my soapbox. Well, it turns out that others were starting to look at this too, and now we have actually 3 really good studies that are much larger. So this is once daily versus BID, again for maintenance. This is a European study. This was a 12-month safety study in 174 patients, and basically that adherence was 93% in the once daily, 99% in the twice daily, and that there were equal relapse rate free groups. And so again, you could do this once a day. Everybody was concerned about safety. Everybody was concerned that maybe you weren't going to have a good relapse rate, and obviously you can have equivalents, and that perhaps maybe once a day was going to be better for a lot of patients. This is the Podium study that was published in CGH a couple of years ago, and at 1 year, 71% in the once daily group versus only 59% in the BID group were in remission, which was statistically significant. So now there's a signal that perhaps these patients who are in the once daily group, maybe taking more, actually are doing better. And so their conclusion was that once daily was superior to BID. And was it because they were getting more exposure to drug, or these were healthier patients? We're not exactly sure. But now there is a paper that says that once a day is better than twice a day. So then the last study, which was just published in Gastro last year, is the Podium study. And you can see by the name that we gave the study that we were assuming that once daily was going to be not necessarily superior, but at least non-inferior. And so this was the acicol preparation. At 6 months, 90.5% versus 91% were in remission, so no difference in the BID versus Q day. The patients preferred once a day when asked, and there was no difference in adherence. So again, 3 nice studies following our small study to show that you could do this once a day. You're going to have effectiveness, you're going to have efficacy, you're going to have safety, and that some patients actually preferred it. So there's no reason today that you need to prescribe for maintenance in ulcerative colitis a 5-ASA product more than once a day. All right, so then we went back and we said, okay, well, now we've got this new formulation, which is actually FDA approved for once a day, and that's Lialda. So we went back again to the similar sort of insurance database claims kind of study, and this time we had 45,000 patients in this. And now we, compared to what I showed you before, we've added Lialda now to this group of medications that we looked at. And we thought, well, gosh, there's a once daily, therapy out there. It's going to kill all the other 5-ASA products. And it turns out that it doesn't, that you still have, look what happened at 90 days. You still had this precipitous drop. Now, not so much in the Lialda group, but over time, again, 12 months, that there's no statistical difference. There's a numeric difference, but no statistical difference in between those who were prescribed Lialda or any of the other 5 ASA products. So maybe in that critical window of the first 3 months, that maybe you're getting some benefit, but that basically, again, it's that 3-month time frame where that interval empathy or that intervention may actually come in really handy, because you're going to lose a lot of people in equal amounts regardless of what medication you give them. So don't think that, oh, well, okay, I'm just going to give them this one that's once a day and everybody's going to go home happy and everybody's going to take their medicine. That it just simply isn't true. So what do patients say? It's easy for me to say, oh, it's going to be easy to take your medication once a day. Well, this was an interesting study out of Europe, just published a couple years ago. 100 patients with ulcerative colitis were interviewed, and asked, well, what's important to you? And it turns out that the most important attribute to a therapy is provide consistent relief. Over 95% of patients said, that's the most important thing. 76% said, yeah, that'd be nice if it was convenient. Only 60% said that once a day was very important to them. They were willing to do it a couple times a day if they got consistent relief. So the conclusion of the authors was that patients care about effectiveness and they care about safety more than cost or convenience, because they're willing to pay if something works, and that they're willing to do it a little bit more if it's convenient. Now, this is a European study. They don't have to worry about cost over there. So I think that's a little bit misleading. But what about in America? So this is data that somehow I still haven't written up back from 2002. But what we did was, well, actually I did write it up as a letter, the follow-up to this. So basically what the IRB did make me do of the cohort that we were allowed to follow, they didn't make me intervene, but what they did make me do was call every patient after the 2 years and tell them what their adherence status was. And so I had to call Mrs. Jones, we've been following you here at University of Chicago, and I've been calling your pharmacy, and it turns out you're not taking as much medicine as we thought you were. Why is that? And they were allowed to free flow tell me why. Or else I could call in, Mr. Jones, it turns out we've been following you for 2 years. You've been taking a good amount of medicine, good for you, and we want to continue in that good vein. So I had to do that with all 94 patients that we had followed. And actually, well, at that point it was 99. We lost 5 patients somewhere in there. But so of the 59 of the 99 that were non-adherent, I just tracked what it was that they said. Why didn't they take their medicine? And 60% said, I just forget. Now, there's intentional forgetting and there's non-intentional forgetting. So not very many thought that it was unsafe or that it was costly. 20%, though, said that they didn't think that they needed as much as they were prescribed. So they were non-adherent by my definition, but they were feeling well and taking half as much, and they were doing fine. So they said, I didn't need as much as you guys were giving me. So that's what really the lack of perceived benefit translated to. So what I did was, I took these data, and then I considered this a minimal intervention of a healthcare professional. And what I did was, after another 6 months, I called their pharmacies back again after this small little telephone intervention, and looked at whether my 10 minutes with the patient on the phone did anything to their behavior, because it can be cumbersome to have the patient come in for a visit. And they don't want to come in if they're feeling well. It's inconvenient, and it bungs up your, it clutters your schedule if they're feeling well. But this 10-minute interview, actually, that 27 of the 49 patients suddenly, for short term, did better. They took more of their medications, and it turns out that 2 of those 27 versus 10 of the other half that didn't change their behavior had a clinical relapse. So that I'd like to think that what I did was I changed behavior and I changed the outcome of their disease. Now, can I prove that? No, but that's what I would like to think. And so that little outcome we did publish.